Our next speaker is a professor of primary care at the Research Unit for General Practice and professor of innovative patient pathways at Silkeborg Diagnostic Center, Aarhus University in Denmark, and the previous editor of the Scandinavian Journal of Primary Health Care. He's going to talk about the role of GPs in cancer diagnosis. Please give a warm welcome to Professor Peter Vedsted.
Thank you so much for that very warm welcome, and thank you so much for this very kind invitation to be here today. It's a great honor for me. I've been to many of these Nordic congresses, and it's always been a big pleasure to discuss family medicine and the development of general practice. And what I'm going to present today is just a small piece that I hope we can use in the discussion of how we could develop general practice in the Nordic countries. What we've heard from the previous very fantastic keynote presentation is that we have a lot of challenges, and general practice is in a leading role in handling a lot of those societal challenges. So what I'll try to do is to jump into the general practice clinical work and try to present an example of where general practitioners really are going to do some diagnosis. And it's also a battlefield of where you can do all the things that we've heard about, medicalization, overdiagnosis, and so on. You might have noticed that I put up the Danish flag here. And of course, it's because I'm proud of being a Dane. We heard that yesterday. It's good to be proud of your country. But in fact, it's because that's the way we celebrate in Denmark. When we celebrate something, we do hygge, and we put up a flag. We're celebrating 20th anniversary of the Nordic Congresses. I want to put up a flag for that. It's a community that we have in common, and it's not a teenager anymore. That's fantastic. But I'm also putting that up because today I have two very good colleagues at the department. Morten is turning 50 today, and Henrik is turning 60. So I also want to celebrate them. Are there anybody in the audience who has a birthday today? One? I can't see you. But congratulations. And isn't that what general practice is about? Taking care of a community, and at the same time, taking care of each person. And that was what I wanted to raise a flag for. Well, I'll start saying I have no disclosures. None of the funders have had any impact or influence on the conclusions or the results I'm going to present today. I'm also standing here on behalf of a very large group of researchers, hardworking researchers. Some of them on these pictures, some of them are here. You can go to their sessions and hear more about the specific research that they are doing at our very lovely university. I'll actually start with a summary of my presentation. I think that then you can go to sleep very securely. The summary is that I think that effective and efficient cancer diagnosis depend on general practice. I think I'll present evidence for that. GPs are one of the finest diagnostic instruments in healthcare. That's not new. We've known that for many years, so I'll present nothing new today. Patients regard the GP as the most essential doctor. No surprise to anyone. GP's diagnostic work affects the cancer outcome. Well, supporting GPs in cancer diagnosis may improve cancer outcome, but what is the right balance? This is the summary of my presentation today. So, why is cancer diagnosis so dependent on general practice? Well, there are three main reasons. The one is that cancer is a public health concern. The other is that diagnostic investigation for cancer is a potential huge, could use a potential huge amount of resources in our healthcare system. And the other is that we need specialists in symptoms to manage the clinical risk in the population. Cancer is growing in the public. During the last 40 years, we have seen a doubling in the number of cancer diagnoses, and 30% will get a cancer before they are 80. So every third in here will have a cancer diagnosis before they're 80. In the next 10 years, we'll see a 20% increase in the number. So there's a lot to do for GPs, a lot to do for the healthcare system, and of course, a number of these cancers are what we would recognize perhaps as being an overdiagnosis. But who they are, we perhaps don't know. On the other side, cancer is a rare disease. Cancer is a very rare disease in general practice. An average GP has only about 10 new cancers each year, but during that year, the GP will have had thousands of contacts with the patients, 10,000 of symptoms and signs. So it's literally like finding a needle in the haystack. Anybody here who has tried to find a needle in the haystack? You do it every day, I think. Let me give an example. This is about myeloma. Myeloma is a rare cancer, but it's important to diagnose, and also to diagnose it early, because we have improved the treatment for myeloma during the years. But it's also known to be a hard to diagnose cancer. Why is that? Because the main symptoms of myeloma is fatigue, back pain, and infections. Have any of you, during the last week, for example, seen a patient with fatigue, back pain, or infection? So there's a lot of myelomas going around out there. How many in here have diagnosed a myeloma in the last year? It should be around 100, I think. Yeah. And how many of you have seen a fatigue last? Everybody. Of all consultations in primary care, fatigue is seen in 10% of all consultations, back pain in 8 to 12%, infections in 15%. So, no wonder it is difficult, it is hard to diagnose cancer. But if it's not going to be the GP who raises the flag for that patient and says, there might be something wrong here, who else is going to do it? So the GP is very important also for all the myeloma patients. So to do that, we need general practice. We need an easy, accessible frontline doctor who is a specialist in managing the clinical risk we see in the population, and who also facilitates an appropriate use of all the investigations that we could use. So general practice plays a very vital role in the movie Cancer Diagnosis. Well, you've been sitting for a very long time now. I know that some of you have got some paper, and perhaps some of you got some a pen. I would like you to have an unplugged activity. We don't trust in IT and smartphones and all that. We're going to do this very old-fashioned. Please find a piece of paper. You can share it. I'm sure that your neighbor would have a piece, just a small one. It's just for writing just one number, a percentage. Okay, quickly, stand up, stand up. You should now find the nearest person that you think you can trust. Everybody should have a partner. Is that a problem? There's a lot of GPs here. You can trust everybody. Everything here is totally confident. Start dating that partner by telling your name. Everybody should have a partner. Okay, look up here. You just look up here and then you answer this question. You shouldn't discuss it. Just in your own head, answer this question. When you refer a 50-year-old patient to be investigated for suspected cancer, what is this patient's risk of having a cancer? You should write that on your piece of paper. So, when you refer a patient that you suspect could have a cancer, how many percentage of them will come back with a cancer diagnosis? It's an easy question. Oh, you shouldn't discuss in your own head. Okay, you've been right. You give it to your partner. You can trust your partner. Give it to your partner. Sit down, please. Okay, we'll come back to the answers a bit later. Well, how do cancers present in general practice? Well, this is basically about elementary, basic symptom epidemiology. What did you learn in medical school? Well, I guess you all, when you remember back just a few years, you were sitting reading the medical textbooks. You always knew what cancer you were looking for. This is a lung cancer, and it might even be a non-small cell lung cancer. And they often had very obvious alarm symptoms. You know, there's 70% had lost weight, 50% had coughed out blood, 30% had been coughing for 2 months. So you could easily spot a lung cancer the next time you went out in the community. But everybody in this room know that the world can be understood in different ways. So I just want you to revisit this figure. I know that a lot of you are familiar with that figure, but it's the ecology of the medical care. It's a typical month in healthcare system. And what we see is that we have 1,000 people up here. Of them, 80% will report some kind of symptom during that month. We'll also see that about 20% will visit a physician, and some of them will go into hospital, and a very, very small proportion will go into a medical department where they write the medical books, the textbooks. And they will write that a lung cancer, the next time you have to diagnose a lung cancer, they have lost weight, they're coughing up blood, and so on. So what they do is that to say we have a high-risk setting and we want to transfer the knowledge from here into the front line of the healthcare system. We know, as Professor Wells mentioned yesterday, we know it's a turtle already. We know it's a rabbit. But do we know as GPs, when we sit out here, do we know it's a turtle? Do we know it's a rabbit with a sign coming in the consultation? No. We all know that if we want to understand how cancer diagnosis is made, we should also understand the low-risk setting. All the symptoms out there, there's a big ocean of symptoms. And sometimes some of these symptoms are presented in your consultation. And then you have to decide, is this a patient in a high risk of having a serious disease or nothing? Or it could be a cancer. And you'll have to decide whether you should investigate today or later. So if we want to be good at diagnosing cancer in our healthcare system, we have to understand the low-risk setting and we have to support the low-risk setting. Let me give you an example. This is a practice population where we have 2,000 adults during 1 year. About 320 of them will have rectal bleeding of some kind during the year. About 20 of them will go into general practice and say, well, I have rectal bleeding. And one of them will have a colon cancer during that year. So of 2,000 people in a year, you will have to diagnose one with colon cancer. Well, the good GP, knowing about the low-risk setting, will know that already when the patient decides to enter your consultation, the risk of having a colon cancer has increased with a factor 15. Don't ever enter a consultation. So it's a good reason to take that contact very seriously. The patient has decided to enter your consultation. And at the same time, you will also know that only one of the 20 patients that had entered your consultation will actually have the colon cancer. Meaning that you will have to investigate all 20 to find the one with a colon cancer. Otherwise, you'll risk to miss one of the diagnoses. We asked the Danish GPs, how did your cancer patient present when you first saw them in your consultation? And surprisingly, they didn't all come with rectal bleeding each time they had a colon cancer. They didn't cough up blood each time they had a lung cancer. Only 50% of all the cancer patients, and of course it was different between different cancers, 50%, half of the cancer patients had presented with what the GP said was an alarm symptom. 20% came, they were sick, I can see that, but I don't know what it is. And 30% came with a vague and common symptom. I didn't get a clue that this could be a cancer. So this is the way typical cancer patients present to general practice. So GPs must be rubbish out there in that low-risk setting with patients presenting with non-alarm symptoms. So we went out and asked a lot of GPs, after each consultation, they should answer this question. Following this consultation, do you suspect that the patient has a new serious disease? And after 6% of all the consultations, that's 1 or 2 each day for a Danish GP, after 6% of the consultations, the GP said, yes, I would suspect that this patient would have a new serious disease. It could be any serious disease. And then we followed these patients for 2 months, and 10% of these patients got a new serious disease in 2 months. This is a fantastic diagnostic instrument to have in a very low-risk setting in our healthcare system. So could we use that GP, that fantastic diagnostic instrument, to improve cancer outcome by earlier diagnosis in general practice, earlier diagnosis of cancer. We've heard Margaret telling about, and also Wells telling about the problems with earlier diagnosis. And I want to stress that what I mean about earlier diagnosis is that we, by timely investigation, we wish to diagnose cancer in an earlier stage. And by timely, I mean it's not something that we just do without thinking. Timely means that we have been thinking thoroughly about, should we now investigate this patient? And an earlier stage means that when we have an earlier stage, we're able to increase or improve the prognosis of that cancer. And I'll only focus on the symptomatic presentation, and that is 90% of all the cancer diagnosis that we are going to make. I'm not going to talk about screening because that's a public health issue. It's not patients presenting in your GP consultation, but 90% of all the cancer diagnoses are made based on patients presenting symptoms in your consultation. Well, what do we know about GPs and the way GPs work and the outcome and the effect on cancer? Well, we can only look at observation. We cannot randomize people to have an inactive GP and then an active, or on a fast track or a slow track. That would be unethical and stupid to do that kind of studies. So we have to rely on observational studies. And what we can see is that if you're listed with a GP who has a higher activity in diagnosing cancer, that could be colonoscopy, gastroscopy, a chest X-ray, or referring to urgent referrals, then we can see that that is associated with better cancer outcome. This is a new, very interesting study that Henry and Henrik, who is turning 60 today, has been just recently done. They identified 124,000 Danish cancer patients, and then they categorized them according to the number of consultations they had 1.5 years before the diagnosis. So it's not in the period just before the diagnosis, 1.5 years before. And what they found was quite interesting. What you see here is the risk of having a late-stage cancer according to the number of contacts that you had in the period before, 1.5 years before. And what you can see is that if you didn't have a contact to your GP, your risk of having a late stage was increased. And then the more you see your GP, the lower risk of a late stage cancer you had. So it's good to have a GP, and it's good to see the GP regularly, it seems. No surprise, of course. We knew that already. Could that be because seeing your GP regularly also means that you would have a timely referral for investigation? It might, because we know that the longer time you have from your first presentation of a symptom to your GP until you get the diagnosis means that you have a higher mortality, and it also means that you have late-stage cancers. The more you wait for your diagnosis, the poorer cancer outcome you can have. We also know that waiting from the diagnosis and until you get your treatment means that you had stage progression. But cancers are stupid. They don't know when they are diagnosed. So that means that we would also see stage progression before the diagnosis. So all in all, that means that it seems that better cancer outcome is associated with clinical activity in general practice, seeing your GP regularly, and time to diagnosis and treatment. So there is something in general practice that affects the cancer outcome. But I know that GPs, every time they think this could be a cancer, they would of course refer the patient. I would think that's the case. So is there any way that we can improve that in general practice? I just want to show you this one study that we made. This is the date. This is for colorectal cancer, and this is the date that the women and the men got the colorectal cancer diagnosis. And then we went 12 months back and measured how often the GP had measured hemoglobin for the patients who got a colorectal cancer and a match group that didn't get a colorectal cancer. And what you can see is that during that year, the colorectal cancer patients seem to have a higher number of hemoglobin. Why do you measure hemoglobin? It's totally random, of course. No. It's because they have some kind of symptom. It's not because of rectal bleeding. It's because they perhaps had fatigue, something like that. We don't know what happened. We don't know what the hemoglobin was. We don't know whether they referred or didn't refer, but we can think about it, reflect about it. That might be a possibility to refer earlier for these patients. And patients know that. If you ask cancer patients that have been through all the cancer trajectory, the diagnostic phase, the treatment phase, the post-treatment phase, surgery, radiotherapy, chemotherapy, and then afterwards you ask them, what was the most important part of your cancer trajectory? This is what is most important. It is to have a responsive GP. It is to have a quick diagnosis. It is to have a quick treatment. That is the most important part of the cancer trajectory. It means a lot to patients how you act upon their symptoms. And we could also measure that if that period were too long, or if you had presented symptoms that might be alarm symptoms, the patients would recognize, and the trust was lower in the GP. The confidence was lower in the GP. That means a lot to the patient-doctor relationship. We heard Martin Marshall mention that yesterday. So there's a lot of methods that we could improve cancer diagnosis. I'll only mention one. We could do artificial, we could do a lot of machine learning in general practice. We could do a decision support and so on. I'll just mention one, and that is about overconfidence. You're not overconfident, I know that. As we heard yesterday, Martin Marshall mentioned that GPs are experts in symptoms, but they are also experts in uncertainty. Diagnosing cancer is particularly difficult. It makes a lot of uncertainty in clinical practice. At the same time, as we heard previously keynote speakers saying, we have this increased pressure from your own work. You're stressed. You want to make fast decisions. There is also a pressure from patients, from society, and that might produce some overconfidence. And overconfidence, we know that increases the risk of cognitive errors and missed diagnosis. Let me give you an example of what I mean by that. This is a study from the US where they had family physicians. They gave a group of family physicians an easy case, and they gave them a more difficult case. And then they measured how good were they at making the correct diagnosis, and they also measured the family physician's confidence. How confident are you that you made the correct diagnosis? And then they gave them first the history, then the physical examination, then the general lab, and the definitive lab and imaging. This is the result from the easy case. What you can see here is that about 60% of the diagnoses were correct. And when they got all the information, they got confused and they dropped. So stick to your first intuition. But what happened to the confidence? Well, it was about 0.7 and perhaps a bit increasing, like the Norwegians. What happened when they gave them a more difficult case? We would expect, of course, that the accuracy would drop, and we would also expect that the confidence would go down, because the family physicians would acknowledge this is a more difficult case. But what happened? Yeah, you can see that the accuracy dropped to under 10% had the correct diagnosis. It really was a more difficult case. But what about the confidence? You should be better than flipping a coin, of course. So the confidence was nearly not changed. Are you overconfident sometimes? I would like you to take the paper you got from your partner. How many of you had a partner who said under 15%? Stand up. All of you. And sit down again. How many had an overconfident partner said over 15%? Any over 50%? I can see a few out there. There are some overconfident GPs, but most of you are actually in a realistic level. That's very good. This is how Danish GPs answered this. You must be a very, very selected group. This is how Danish GPs, 568, less than you, I know, Danish GPs answered this question. What you can see here is that 1 in 5 said, well, it's under 14%. But 40% said it must be over 50%. When I refer a patient for suspected cancer, I'm a very good doctor. I have the correct diagnosis. Is that a good thing for the patients in general practice? Very promising to see your confidence today. That's good for the patients. Well, the last thing I'll present is some experiences from a system change in Denmark. There was in Denmark a problem back in 2007 where we found out that cancer patients waited very long for having a diagnosis and waited very long for getting treatment. Then there was a logistic reform of the cancer pathway, meaning that from 2007 and 2008, GPs could refer urgently to investigation within a few days. They could refer urgently the patient to either an organ-specific pathway, meaning that if you had rectal bleeding, you would go into the colorectal cancer pathway, or if you had these unspecific, non-specific symptoms, but you were sick, you could go into the diagnostic center. That has also been introduced now in Norway and Sweden. It would be very interesting to see what the effect would be there. What have we found in Denmark so far? We have found that the patient satisfaction has significantly increased. We have significantly shorter diagnostic intervals, and we have also seen a lower mortality among those who are referred. So it seems to be some kind of positive outcome. Another way we can look at it is the change in 1-year cancer survival. And if we compare Denmark with Finland, Norway, and Sweden for women and men, respectively, you can see that in Denmark, we were able to have the biggest increase in 1-year survival from before the system change and until after the system change. It seems that something has changed in Denmark by changing the system and making it possible for GPs to make urgent referral if the GP suspect that this could be a cancer. Of course, we have to be careful because it could all be lead time bias. We know from screening that if you make the diagnosis earlier, it could looked like the patient had a longer, would survive longer, but in fact they were dying at the exact same time. So we are just making the diagnosis earlier. So that is the lead time. A recent study using real mortality data from before to after in Denmark found that 12% of that survival gain that you saw before, 12%, and that was we would expect some lead time. 12% could be ascribed to lead time. So the majority of that gain we saw in Denmark can be ascribed to that we actually had a survival gain in cancer. And then there are all the possible side effects. We've heard a lot about them. The question is, these patients came with symptoms in general practice. So how are we to balance that? We could have side effects on patient-related, could be concern, anxiety, we've heard about that. It could also be an overdiagnosis of that exact cancer. We could have incidental findings that need follow-up. It's clearly something different from overdiagnosis. There are safety issues. We could send people to tests that are actually not safe. And there's a lot of financial issues. The solution to that question is that we need much more multidisciplinary primary care-based research on relevant population. We cannot take public health research on screening and try to implement that in general practice setting. We cannot take public health research on turtles and put that into a GP's consultation. So the key messages from my presentation of what you can do on Monday already is that I think that I've given some support that there are 4 important adjustments that we have to make. We often hear that there is no evidence that earlier diagnosis is important. I think I've shown that it might be important to make earlier cancer diagnosis. It might also be possible. We also often hear that cancer diagnoses are made at hospitals. That's not true. Literally all cancer diagnoses start in general practice. We also hear that GPs are not particularly good at diagnosing cancer. That's not true. GPs are even better than most obvious alarm symptoms we have given the circumstances where GPs work in the low-risk setting. And we often hear that the proportion of cancer must be high when you refer to investigations. And we now know from the low-risk setting that the proportion of cancers must not be too high, because then you risk to miss some cancers. And what can you do already on Monday? I think you could remember that you work in a low-risk setting, the most difficult setting in the healthcare system. You could also recognize clinical uncertainty. We've heard about it, and I know that Guri or Advait tomorrow will go deeper into that. I really look forward to hear more about clinical uncertainty. And you could also work with clinical uncertainty to be a better generalist, because that's so important. Then you could try to avoid overconfidence. You've all learned it. But there's a lot of other GPs out there who should also learn what overconfidence is. You have a vital role in cancer diagnosis. We know that the patients trust that you fulfill that role. The problem is, how do we balance that role in the correct way so that we do most positive things for the patients and less harm? I'm absolutely sure that I've given a small piece of evidence to your daily clinical work, and thank you for listening.